All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. It helps, these exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
now.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So
Indeed.
Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone, and welcome back to the GynoCast. My name is Dr. Eric Heegaard. I am here with Twila Dang.
Why did you say my name like
I
that
just wanted
today?
I wanted to see if you were going to jump in. I'm here with my co-host.
You think I'm going to rush and be like, I want to say my name.
I just love to just.
I say my name all the time. I'm okay.
I spent so many years having to wait for you to introduce me that I just love. I just like.
Hey, now I felt like I did that efficiently.
You did a great job. No, but
Thank you.
it's exciting for me to be in this new position where because for those of you who don't know,
drunk
Twila
with
and I
power.
did live radio for a number of years,
Yes.
and Twila would always introduce me, and now I'm kind of introducing, and so I love the idea that I can just kind of.
You're essentially drunk with power.
I am.
now.
I'm drunk with power. That's exactly right. So, for those of you who don't know us, I am a board-certified obstetrician and gynecologist, and you are listening to the GynoCast. And what do we do here on the GynoCast, Twila?
We talk about anything and everything women's emotional and physical health and well-being.
That's right. We talk about things that people really need to know about and want to know about, but sometimes don't know where to go. And so, we talk about topics that sometimes aren't necessarily the things you'd like to talk to your boss, for example.
No, you made a great analogy if you
your mother.
podcast back. Yeah, if you're things that you're not comfortable talking to your mom about, we talk about here.
Yeah, we can talk about that here.
Yeah.
But also, let's just say you're at an office party.
Okay.
And you're just kind of milling about, and you have a gin and tonic.
Mm-hmm.
And if you want to know Dr. Heegaard's customized recipe
No,
for gin and tonics,
we're not-
you got to listen to the other show, which I can't remember.
Yeah,
which
it's
one
in
it
the
was.
syllabus for another show because he's been obsessed with these gin and tonics.
I make
lately.
a damn good gin and tonic.
Yeah, but it's available.
Effervescent,
We'll put it on the Facebook page.
fruity, refreshing on a summer night.
Okay.
So, where were we? Oh, if you're not, we have, for those of you who are new to listening to the GynoCast, welcome aboard, and thank you for listening. For those of you who are returning, we adore you.
Thank you.
And if you're not a member of the GynoCast Facebook group,
You should
shame on you.
Stop shaming the people. You made
did
it so long without shaming the people.
Oh, there's nothing like a good shaming.
No, we don't need to shame the people. We're happy that you're here, and you just might not have found us yet, so let us
That's
help
right.
you.
The life-changing GynoCast Facebook group. We're almost up to 2,000 members.
Yeah.
So if you're on Facebook, just search the GynoCast.
Indeed.
And you'll pop up, and we will. You have to
Join
ask
the
to
page.
join.
Yeah, you have to ask.
And then we will screen you briefly.
Yes, it's a private group.
Mm-hmm. And we will invite you aboard where you can be a part of this life-changing, edifying group where you can engage in civilized, sometimes controversial conversation.
But
Suggest
always
shows.
Those discussions are always done super respectfully. I think we have a really safe space where you can agree to disagree, but we share good, solid information. It's not just folks yelling at each other about their opinions. It's really people who are thoughtfully engaging in discussions.
That's right. And if you are not, I'll always say, this is what I say. I'm going to say we, but I'm going to say.
Okay.
Which is that I still believe that we can live in a society where we can have civilized conversations about controversial topics. That's
Absolutely.
all. We will talk about real facts, not alternative facts. I know that was going to agitate Twila.
I'm giving you the look. It's fine.
I'm just doing that
I know.
Just to poke you, poking the bear.
I know.
And so, anyway, today we are going to talk about ectopic pregnancy or tubal pregnancy. We're not going to spend. This is not going to be a 2-hour show, but this is something that people know about, especially if you've been pregnant, and a lot of women had friends or maybe had this happen themselves. But this is something that we need to get the information out about in terms of what to look for, because it can be life-threatening. And, as we've talked about on some different shows, if you walk through cemeteries, which I kind of enjoy doing.
I don't understand how the cemetery thing is becoming like...
It's fascinating, Twila. If you walk through a cemetery in an old church, it's littered with women and babies.
Well,
and young women. And it's littered with men. But, pregnancy is not a safe state for women. It's not, no matter what anybody says.
Okay, I'm concerned that we're making it... I know it's not biologically like a safe space.
Next up, birth control.
Yeah, there's a lot that we do, that we go through, but I don't want us to underscore something that today's guest has said in the past, which on one of our podcasts, which is, yes, you go through all of this, but in the end... I'm not trying...
You're right.
Wonderful...
You're right.
This wonderful... And it is really and truly... It can be a wonderful transformational process. I can say that as a woman who has had 3 children, who never intended to have children, the whole trajectory of my life changed by having them.
Exactly. So, I'm not trying to minimize that at all. I'm just saying
I went through some stuff, but still.
Later on in the episode, Twila talks about her stuff.
But yeah, I don't want to underscore that while we're talking about really important things. I don't want us to terrify anybody.
God almighty, Twila. I'm just trying to say that it is a state that deserves respect and
reverence.
And reverence, and the fact that it is not a normal state. When a woman is pregnant, she has at increased risk for many things.
Yeah, it's not a walk in the park.
It's not a walk in the park.
Yeah.
And pregnancy is natural, but so are hurricanes. How do you like that? Kaboom, Twila. What are you going to say now? Kaboom.
You just
Speechless.
equated hurricanes to pregnancy.
This is the first time you've ever heard Twila speechless for one
but not
second.
in a good way.
Kaboom! Okay, so our guest today is a GynoCast veteran, Dr. Matt Bigus from OBGYN West. Dr. Bigus is a smart guy, described by many of his loving patients as being a swarthy teddy bear. A walking chocolate chip cookie.
Thank you for having me back.
When you see him, you just want to give him a hug.
Okay, I'm just telling you right now. When they show up on T-shirts, because there's no way they're not going to show up on T-shirts, I'll just cut you in. I'll just make sure you get your 10% on the back end. Because you just called him a walking chocolate chip.
He is. Don't you want to just give him a little hug and smell his neck?
Just don't take a bite out of it.
Just want to take a little
teddy
nibble.
Bear was already like... Okay, you know what, though? Wait, sidebar. I will say that. I have an obsession with, like, when people meet celebrities and I haven't met them, the first thing what do I always ask? I always ask how they smell like. Yeah, I'm obsessed with that. I have a thing about smell. You do smell good.
Oh, gee, thank
you. That's a good thing. So, yeah.
Do you bathe weekly, doctor?
Today was my weekly shower.
Good for you.
All right.
His man musk is...
So the swarthy teddy bear that winds up on this T-shirt.
If you want more information on Dr. Bigus...
we'll provide actual information, not just his status as a walking chocolate chip cookie.
And look for our new segment. Night Out with Bigus. Mm-hmm. I know, seriously, I want to do this. Time Out with Bigus. We're going to show Dr. Bigus and Twila and myself. We'll be exercising. We'll be making...
Do we have to exercise?
Baking chocolate chip
cookies. Baking chocolate chip cookies.
I'll
Dr. Bigus's recipe for garlic shrimp, which he just told me he tried to make the other night, and it exploded.
Oh, you give that man a hard time.
Was it garlic shrimp flambe, doctor?
We were talking in a safe space, and you tell that to put his business out there.
Gas stoves get hotter much quicker.
Yeah, so
that's what I learned.
What we know... on the GynoCast, we say this. Life is about change and growth and evolution, right?
Yeah.
And we're all growing.
Indeed.
Okay, doctor, thank you for coming back and joining us here.
Thank you for putting up with our shenanigans.
Thanks for having me. I appreciate it.
Let's talk about ectopic pregnancy.
Sure.
What is ectopic pregnancy?
So a simple definition for ectopic pregnancy is it's a pregnancy that's located outside of the uterus. Normally, when someone gets pregnant, it's what we call an intrauterine pregnancy, or pregnancy within the uterus where it belongs. An ectopic pregnancy is a pregnancy anywhere that is not inside the uterus. The incidence for this has been about 1% to 2% in all pregnancies, and that's been pretty well stable for the most of all time. Although there has been a recent uptick in some of the ectopic pregnancies, and that's we attribute that to the increase in vitro fertilization.
Interesting.
Although with that changing a little bit and then doing single embryo transfers, that number's kind of coming down a little bit than what it had been previously when they were Octomom and John and Kate +8.
So what? So an ectopic pregnancy is, as you said, a pregnancy that occurs somewhere else besides the womb.
Correct.
Now, let me ask you something. A little trivia.
Okay.
Ready for this, Dr. Bigus? I can
love
see him.
trivia.
He starts swallowing. I like to see him. Bigus is hard to, he's hard to.
You can't rattle him very
You
easily.
can't rattle him. You can't. You nudge him, and he just.
Thank goodness.
But okay, where's the word womb come from?
Wow.
Oh, that's a good one.
I don't even have my phone. I can't cheat right now.
Womb.
From Latin.
Is it a speech? Is it someone who says it wrong, like a room, and they say it by accident? Womb.
You mean like how they meant to name Oprah Orpah, but they misspelled it, so then she became
Womb?
Oprah?
Yeah.
Oh.
Womb. Is it? Do you have a womb at the end? Well, actually, the word womb comes from the Greek and Roman etymology that has to do with womb at the end. I have no idea.
Yeah,
actually, I have no idea. I was just winging it. But I just thought maybe if anybody would know, Bigus might know. And Twila, you seem to. Will you look it up while we have a second? Because where does
I can't
womb?
look it up. Now I have to put it in the syllabus. Now you make it work for me.
The amazing thing is, Bigus, you don't know this, but Twila has got an encyclopedic knowledge of she can pull things out of just nowhere.
But it's
unbelievable.
useless information. Usually. Like you can ask me like who the kid was that starred in the TV movie like My Face on the Milk Carton in 1983. I can tell you that. This is a little tougher. And I even took Latin, so sometimes when you throw words at me, I'm like, got it, it's Latin. But you got me on that one.
So when I think of womb, by the way, and we are going to get back to our topic here in a second, but when I think of womb, I think of one of the weirdest medical historical theories that has to do with the Greeks. I think it was who was Bigus? Who's that? We all take
I'm waiting for the question.
What's that?
Julius Caesar.
No, that was about that. That's good. We talked about the Caesarean section, but who is the father of medicine that we?
Asclepius.
That's very good. That's isn't that the snake thing?
Yeah, that's the guy who had the caducee, the cross with the snake on it.
Yeah. Well, that's not who I'm thinking about. But they used to think Twila. Do you remember we were talking about this, Twila, at one point? The wandering womb.
Yes, we did talk about this.
The Greeks actually thought that the womb was not a static situation. Like the womb was not somewhere that just stayed there. They thought that certain disorders were related to the womb kind of wandering around the body.
I recall this.
So we'll have to bring that up in our historical, medicine segment at some point, because I got to go back to that, because that is just, there are times when you just realize that, and maybe people feel like this now, but you really were taking a risk when you went and saw a doctor or a practitioner back in those days. And, they might just say, well, maybe your womb is wandering. That's not good.
Things.
Yeah. All right, Bigus. I'm not going to let you distract us again. Enough of your.
That's it.
Enough of your womb wandering. So, oftentimes the ones that we see most of the time is that the pregnancy is in the tube.
Correct.
But also it can happen elsewhere.
Absolutely.
Really, because I usually only hear about. I guess when I say I'm not a doctor, so I only ever hear about it being like in.
Well, of course you are. Tube. You didn't know where the womb or the etymology of womb was. What do you know?
But I'll know by the end of the day.
Mm-hmm.
So likely places, the most likely is actually in the fallopian tube. Other than that, the other places that a pregnancy can implant is the ovary. It can implant all the way down in the cervix. It can implant kind of in the corner of the uterus. It's a fancy word that we call cornu, which is Latin, I believe, for corner of the uterus.
Today is Latin.
Mm-hmm.
Is that Latin today, or is it Greek?
Yeah, actually, that sounds Latin, but I'll double check it.
So it can be up in the corner where it doesn't belong because the uterus wouldn't expand correctly. It could be in the cervix, could be in the ovary, or it could actually be in the abdominal cavity itself. There's actually recently...
I was going to say, go for it.
...been a case report out of England.
I don't know.
I believe it was England, the Royal College of Surgeons, where they found a intra-abdominal pregnancy that was attached to the liver.
Oh, I didn't read this.
They delivered the baby. I think they did methotrexate followed by a small liver resection, but I'd have to pull the article to be accurate. So don't.
Okay, well, I guess there's a quick question: Are pregnancies that occur outside of the uterus viable pregnancies, or no?
Normally, no. Extremely rarely, they can be.
Okay.
And those would primarily be an intra-abdominal one where the pregnancy would implant on something called the omentum, which is the fatty apron that lays over top of the bowel.
Yeah,
so,
that's what I was thinking you were going to talk about. That's
Well, there's been case reports definitely of that, but I think the most recent one that I've heard about was one that had implanted onto the liver. I believe it was out of England. I'd have to pull the article and find it too.
So it can be anywhere, but really most of those other ones are sort of just for academic interest and trivia.
Absolutely.
But so what is you said about 1% to 2% of pregnancies, and why does it matter that we care?
Absolutely. So back in the olden days, ectopic pregnancies almost always resulted in mortality, and why I'm saying that prior to the 1800s. Bit of trivia for you.
Okay, good. Medical trivia.
Who was the first surgeon to successfully treat an ectopic pregnancy? Or when?
Well, I have no idea.
1883 by Lawson Tate in England.
Dr. Tate.
Dr. Tate.
Wow.
Mm-hmm. That was the very first surgical treatment of an ectopic pregnancy where the woman did survive. Since then, there's been a pretty steady decline in the mortality rate. In fact, it's been about a 10-fold decrease, I believe, since the 70s until now in the rate of mortality from an ectopic pregnancy. Now, regardless of that decrease, there is still a risk of mortality with this or death from an ectopic pregnancy. In fact, 1 in 5 deaths in African American women in the first trimester of pregnancy are secondary to a ruptured ectopic, where the pregnancy itself actually ruptures the fallopian tube and they hemorrhage so bad that they can't get to the hospital in time to have a life-saving surgery for them.
Wow. Is that sort of tied to other issues like prenatal care and things like that, most likely?
Partially. Usually unfortunately for these women who suffer from mortality from this, it's usually there is a late presentation or they don't have regular periods, which is more the concerning part, especially if you don't have a regular period and you get pregnant, you don't really know it because you don't really know when your menstrual cycles are happening.
Mm-hmm.
And no one's really identified where that pregnancy is. And then you just begin having pain, and it can rupture, and unfortunately, massive catastrophic hemorrhaging following that.
Yeah, so this is, again, this is a topic that people need to know about. It's just, it's not just of historical interest, and this happens now, and the importance of being able to identify it and treat it early is a big deal.
Mm-hmm.
So what are risk factors?
Sure. So risk factors, obviously, if you've ever had an ectopic before, that's probably your largest risk of having another ectopic. Other risk factors include any type of inflammation of the fallopian tubes that you could have had. Things such as a prior sexually transmitted disease such as gonorrhea or chlamydia can do it. Endometriosis can cause inflammation of the fallopian tubes and therefore put you at increased risk for ectopics. In fact, smoking itself can damage your fallopian tube lining and would not allow the embryo to travel through the fallopian tube as it's supposed to and get hung up there. And cause an ectopic pregnancy. Some people have said IUD use, but when you look at IUDs, because I know that's been out there, that a lot of people sort of mistakenly believe that an IUD insertion causes an increase in ectopics. The overall rate of ectopic pregnancies with an IUD is the same as people without, but in people who get pregnant after an IUD insertion, it's more likely then to be an ectopic pregnancy.
All right.
Also, getting your tubes tied. One of the very minor, small risks with a tubal ligation is that tubal ligation fails. But in those women who do have a failed tubal ligation, which is less than 1% of people who undergo the procedure, those pregnancies are more likely to be within the uterus or within the fallopian tube and outside the uterus than within the uterus itself.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
So before we go too much farther along with this, can you tell us a little bit about, the process of actually fertilization plays a lot to do with this, because most people, I think, believe that fertilization, you got the egg and the sperm, they connect and they implant inside the uterus. But in fact,
occurs in the fallopian tube.
Yeah, that fertilization almost always occurs there.
Absolutely. So usually a woman will ovulate. She'll ovulate off of her ovary. And once the ovulation occurs, you form a big, large cyst on your ovary. That cyst then kind of extrudes the egg, which the fallopian tube will pick up. The end of the fallopian tube, it has what we call fimbria. Fimbria, I believe, is another Latin term for fingers. And those little fingers kind of pick up the egg and suck it up inside the fallopian tube. Then there's small little
hairs,
that's a good word for it, that sort of sweep the egg towards the uterus. Now, simultaneously...
You know what I think of when I hear that? What is that thing like in a rave, when somebody jumps off the...
crowd surfing?
And so they're kind of passing the person. That's what they're doing.
Exactly like it is.
The fallopian tube is what did you call it? Crowd surfing? Is that what it is?
Yeah.
Crowd surfing the egg down. These little hairs are kind of moving it down.
And then the ectopic happens when someone drops you when you're crowd surfing.
There you go. We have just, and seriously, is that a good visual? I think
Actually,
it
that's
is.
a really great visual, yeah. Mm-hmm.
Or, so it gets dropped, or because of inflammation, infection, that sort of things.
It doesn't get swept in the right direction, kind of like in circles around the middle of the crowd.
Yeah,
never back up front to stage.
Yeah, right, exactly. I like it. I think that's pretty.
That all makes perfect sense to me.
Flipping good. I love that.
Yeah.
All right. So, and inflammation makes it perhaps go in the wrong direction,
Correct.
or
doesn't they don't even move at all. There might not even be any.
They may be armless.
Right.
Yeah, because it damages and destroys those little cilia, those little hairs that are moving along. So you've got a bunch of people who can't grab you. I'm trying to make this so it doesn't sound too gory. A bunch of armless, zombies. It's what it is. It's a bunch of armless zombies at this concert. God, it's terrible, Dr. Bigus.
Yeah. Okay.
That's not a concert I would want to go to.
No.
Oh, this around Halloween, that might be a lot of fun,
turn.
Right?
Okay.
So as the egg kind of travels down the fallopian tube, the sperm and the semen actually travel in the opposite direction, and they usually meet somewhere in the middle of the fallopian tube where actually fertilization occurs. That fertilized egg then continues to be swept towards the center of the uterus itself, where eventually within about a week or so it would implant into the wall of the uterus. Creating a viable, normal intrauterine pregnancy.
So why does fertilization occur in the tube and not in the uterus?
Well, usually for some reason that fertilized egg does not travel through the tube, whether there's a blockage, the little hairs or the cilia don't work correctly, or for some reason that tube just does not cause the egg to traverse its length and into the uterus itself.
But from an embryological standpoint, why doesn't fertilization occur in the uterus? Why does it occur in the fallopian tube? I'm sorry. I just had to throw it out because nobody knows the answer to that.
Yeah,
I couldn't even keep a straight face. So there are certain things that are just a part of the magic.
Mm-hmm. Well, if you look at like dogs have a bicornuate uterus where it's actually one long tube on either side, which is why they can have a litter of puppies. And rabbits have something similar, and that's why they can actually get pregnant while they're pregnant, because they have two long tubes on either side. So I think it's just developed that humans have
wow, look at that.
Learn something new every day.
Yeah.
Versus a litter.
Well, then I'm just going to say thank you to whatever biological gods decided that's how we were going to get designed, because I certainly don't want to have a litter. Thanks.
So the things that put you at risk for this happening again are what Dr. Bigus was saying, that anything that damages that fallopian tube, infection, previous surgeries, endometriosis, which is a whole different topic.
I really didn't know about the infection. Like we've had a couple of episodes about STDs specifically, and knowing that that's a part of we've all heard this conversation, had this sort of part of the conversation before about disclosing all of your medical history to your doctor, because there are, I think we don't even think that there's an inherent risk of having had an STD in terms of future pregnancy a lot of the time.
Yeah. And so previous infections, you were saying previous ectopic. And so
what about genetics? Is like if your mom had them, or does that play at all into it?
I mean, it could.
Why, doctor? Why?
It could increase the risk, but there's not really not necessarily. It hasn't really been shown to be linked with genetics, scientifically, like statistically proven that way. But we'll see it occasionally. It'll run in families a little bit like that.
Okay.
But there's not actually like a.
Well, that is not fair.
Why?
You're asking him questions that nobody knows the answer to. I mean, he's doing a great job. It's like saying, everybody in my family from the 1800s is dead. Does that run in family? Is that something I have to worry about being dead at some point? It's not fair.
I felt like that was a valid question.
Well, I see. One of the other things that does increase your risk is also age. The older that you get, the less likely that the fallopian tube is going to be able to move the egg correctly.
Why do you think that is? And does anybody know, or is it just?
That's also not a lot of people know, but it's probably more years that you can accumulate some type of inflammation or damage to the fallopian tube itself. So unfortunately, older women who do get pregnant are more likely to have an ectopic pregnancy. And in the United States, we're kind of seeing a shift in reproductive age, a little bit older now, especially with the advent of the infertility medicines that help to conceive at an older age, and sort of the shift in culture where people for the most part are trying to get go to college, get established, and be able to sort of plan their life out around children, as opposed to 50, 60, 70 years ago, or worked a little differently.
So what is the presentation for a woman who has an ectopic pregnancy? What is going to happen? What is the most
common is pain. They're going to come in, they're going to tell you that they have a lot of pain. But even more common than that, a lot of times when we see people, they don't even know that they have an ectopic pregnancy. It's usually, it doesn't really cause you pain until it's kind of on the verge of getting ready to rupture or break through that fallopian tube. Now, if you think about your uterus is designed to grow large, almost the entire abdomen, to support an entire baby. But that fallopian tube is maybe about the width of a pen. That would not be able to sort of support a growing fetus and growing embryonic sac. So the larger it gets, the more likely you're supposed to get swelling within that fallopian tube. And that swelling of the fallopian tube, as it stretches and stretches, causes you that pain, which is kind of the herald symptom for it rupturing and starting that catastrophic hemorrhage. Now, one of the things that we look for...
And bleeding sometimes, too, right?
Absolutely. So bleeding is going to occur as well. Usually not necessarily bleeding like a menstrual cycle, as much as it's more of spotting or small amounts of bleeding with an ectopic. One of the things that we look for in our physical exam, is part of the reason why you get that first physical exam, is we feel on either side of the uterus, where we feel for what we call the adnexa, which is sort of all the structures that live next to the uterus. We're feeling at the ovary, we're feeling at the fallopian tubes. Make sure that we don't feel any masses on either side. Because if in pregnancy we do feel a mass on that side, and I don't have an ultrasound picture to verify where your pregnancy is, then based off a physical exam alone, then I am concerned that mass I feel would be a pregnancy outside the uterus where it doesn't belong.
Okay.
And so, just from a kind of a practical standpoint, if you are pregnant and you start developing bleeding and pain, they should
come in, let your physician know, be seen right away. Bleeding in pregnancy is very common, but it is never normal. It's always a good idea for us to come and evaluate why you're having that bleeding, to make sure it's not one of these catastrophic things such as an ectopic pregnancy, God forbid a miscarriage, or any other issue that would cause you bleeding early in pregnancy.
Is there even a difference in say like the color of the blood that you're seeing that would kind of like extra set off alarm bells or anything?
Not necessarily color for me as much as amount. I'm more concerned if you tell me that you're having a large amount of bleeding like a menstrual cycle, that you're miscarrying. But if you're telling me that you're having constant spotting associated with some pain, that's going to make me think more ectopic. But the amount of bleeding, the color of the bleeding is not a diagnostic tool by any means. It just kind of leads me to suspect what might be going on, but I would not stake my claim or hang my hat on any of those symptoms.
Okay.
How do you diagnose it?
Usually diagnosis is by ultrasound. One of the old-fashioned ways to diagnose it is a positive pregnancy test, either by urine, a mass plus pain on either side of the uterus, and blood within the abdomen or pelvis. That's sort of before ultrasound was how you diagnosed an ectopic pregnancy. You could, one of the old ways to do this is you would take a long needle and you would stick it through the back of the vagina into the pelvis itself, and if there was blood in that pelvis, bloody fluid, in addition to the woman having a positive pregnancy test and a mass or having pain, that would be an ectopic pregnancy until proven otherwise for us. Now with
we don't do that anymore.
Yeah, but say thank you. I was like, they can see you can't. It's
advent
not
of ultrasound. We do not have to play those tests anymore, which is good. Sort of a historical perspective. But with the ultrasound, we would be looking for a mass on either side of the uterus where that adnexal structures or the fallopian tube in the ovary is. In addition to that, having an empty uterus.
Yeah, so an absence of an embryo or something inside the uterus and a positive pregnancy test and a mass.
Mm-hmm. Okay.
Now, as Dr. Bigus was saying, is that in the old days, and this is even pre-me, before laparoscopy, really, and they were looking for, because the decision was going to be whether you were going to make a big incision and open them up.
Absolutely.
And so this, that was, you had somebody who was pregnant, you had somebody who had pain, and they'd put this needle in there, and they'd get blood, and they'd be like, okay, time to go. And they'd make a big incision. And
when you say big incision, what are you talking about in terms of like inches?
An incision about the same size as a cesarean section.
Oh, okay. So that's a good size incision.
Yeah. And so now, and I don't want to get too deep into the kind of, details of diagnosis, because sometimes it's obvious and sometimes it's subtle.
Right,
exactly. But what are some of the options for management or treatment of this?
Absolutely. So let's say that we've identified an ectopic pregnancy, and then there's kind of two pathways sort of we take. The first pathway is going to determine whether or not it's ruptured. If it's a ruptured ectopic, meaning that you're actively bleeding, the only option then would be a surgical management.
So by that, it's probably obvious, but the egg, the embryo is implanted into the wall of the tube, and it has now gotten big enough that it is blown out. It's exploded through the tube.
The fallopian tube has now ruptured and is just hemorrhaging inside. If that's the case, obviously the last thing I want to do is give you medicine and wait a week. I would want to treat you right away, take you to the operating room. Now we no longer do large incisions. We can do this with laparoscopy, assuming that you are what we consider quote-unquote stable, meaning that you're not actively on the cusp of death. If, God forbid, it is to that point where we're worried that we have to give you blood products and you're not maintaining your blood pressure because you're bleeding so heavily, then we would have to make a large incision in order to stop that bleeding. But if it is just sort of on the verge where it has just ruptured, it is absolutely able to be taken care of with surgery itself. Small incisions, usually one at your belly button and two over either hip, would be enough in order to treat that to help stop the bleeding itself. Now, if it's not ruptured, we kind of go down the other pathway where we can consider medical management versus surgical management. Not everyone wants to attempt a medical management of an ectopic pregnancy. Some people would prefer just to have surgery to complete the treatment and take care of it. It kind of depends on what your own personal unique situations are. For example, if you're older, you weren't trying to get pregnant, you prefer to have your fallopian tubes tied, well, that's a great option for us to go with surgical management. Versus...
And you would probably remove the tubes at that point.
Correct, absolutely. You remove both of the tubes and then hopefully prevent any further pregnancies, let alone ectopics in the future. The other option would be, let's say it's a young woman, 20 years old, wants to start a family. This is the first time she gets pregnant. The last thing I'd necessarily want to do is have to go in and remove a fallopian tube with an ectopic pregnancy and allow her, 2 ovaries and 1 fallopian tube, which may diminish some of her ability to get pregnant in the future.
And as Dr. Bigus, I'm sorry to interrupt, but as Dr. Bigus was talking about, is that when we go in there and the ectopic is ruptured, blown through the tube, and they're bleeding, generally at that point, at that point, we're taking out not just the pregnancy, but the tube itself.
Yep. Right. Because repairing the fallopian tube and putting stitches in it is just going to be a nidus for a future ectopic pregnancy as well. So it really is a individualized choice as to how to treat you. Hopefully with that young woman who wants to have future pregnancies, one of the things that we can do is treat you medically with a medication called methotrexate. Methotrexate is a sort of a multi-use drug. It's what we call an anti-metabolite. It means that it sort of replaces a folate, which is a natural vitamin that your body uses to have cells grow. When cells are growing, such as a pregnancy, it needs lots of folic acid in order to replicate those cells, increase the DNA, and if you give methotrexate, it kind of replaces that folate so your cells aren't able to grow, and instead those quickly dividing cells will oftentimes die off. That methotrexate we can give you now, granted there are some contraindications, some reasons why we wouldn't give you, it wouldn't be safe, and that's a good reason to kind of review with your doctor this option for treatment to make sure that you don't have one of those contraindications to the medication itself. After giving the medication, we usually monitor you over the course of a week. We ask you to get blood counts a few days after and then 7 days after the treatment of the methotrexate. We watch those blood counts for your pregnancy hormone to make sure that they're dropping appropriately. If they're not dropping appropriately, you may need a second dose of methotrexate, or, depending on the situation, may need to go to surgery to kind of complete the resolution of the ectopic pregnancy itself. Now, very, very rarely would we encounter a situation where we could do what we call expectant management of an ectopic pregnancy, which means just to watch you and sort of see and watch your body resolve this on its own. Your body does have a compensatory mechanism to resolve and resorb an ectopic pregnancy, but that would be an ectopic that at the time that we diagnose it is currently dying and resolving on its own, meaning your body is already doing this. If the ectopic pregnancy is growing, getting worse, getting bigger, I would not recommend expectant management whatsoever.
And when you think about it, 100 years ago, people, not everybody died of an ectopic.
Right.
Probably most women did, but it would be because sometimes it just resolves on its own. So, one of the take-home messages I think we're hearing here is that, number one, know if you're pregnant. Number two, if you're having bleeding or pain, call as early as possible, because ideally we can identify an ectopic pregnancy early, and in many cases, we can treat it medically and thereby preserve the fallopian tubes and a woman's fertility. All right. Okay. Anything else you need to say, Doctor? No. This is one of our shorter ones. I thought we'd just try this. Let's just get it done. Boom, boom, boom.
I like it.
Twila, any comments?
No.
Thank you for listening.
I'm glad that they stopped doing that. I'm just glad the information is getting out there, that we have good, solid information, and it's easily accessible, and that we're able to provide a platform to do this. So
that's right.
I like that.
All right.
Thank you very much for having me back.
Thank you, Dr. Bigus.
Indeed.
Thank you, Twila. Thank you for listening, and we will see you soon.